Welcome. Thank you for joining us. My name is Michaeline Friedenberg, and I'm the president and CEO of the Institute of Reproductive Grief Care. I'm joined by Rebecca Capuano, Education Program Facilitator for the Institute. For those of you who are new to our organization, let me start by briefly sharing our mission and the goal of this webinar series. The Institute of Reproductive Grief Care is the global expert in evidence-based trauma-informed grief care education and training for healthcare professionals, mental health providers, and community leaders. We're at the forefront of creating and distributing impartial and impactful research to understand the way individuals process reproductive losses. This Research in Action lecture series, in honor of Pregnancy and Infant Loss Awareness Month, features in-depth discussions with the authors of some of the latest groundbreaking reproductive loss research. Thank you for joining this important conversation. I also want to thank our co-sponsors, Burnham Center for Community Engagement, Indiana University, Indianapolis, and San Diego Magazine. We are grateful for their support and for their dedication to improving maternal mental health through education, research, and positive policy change. For all those who are personally impacted by reproductive loss, please accept our condolences and be assured that you are not alone. We remember you and stand with you. And with that, I'd like to turn things over to Rebecca.
Thank you, Michaeline. Today, we are honored to feature four esteemed researchers. First, Dr. Shandy Nikki Berry's research in perinatal loss, grief, and bereavement has been presented throughout the world, published in multiple peer-reviewed journals, and incorporated into nationwide perinatal palliative care curricula. Dr. Berry serves on nationwide committees and task forces with leading perinatal loss organizations, including the Institute of Reproductive Grief Care and the Perinatal Loss and Infant Death Alliance. Next, Dr. Gloricel Gonzalez Vieira is double board certified in psychiatry and sleep medicine by the American Board of Psychiatry and Neurology. She is assistant professor at Baylor College of Medicine, where she works as a reproductive psychiatrist at the Women's Place at Texas Children's Hospital Pavilion for Women. And she serves on the Institute's Healthcare Task Force and Screening Tool Working Group. Next, Dr. Rebecca Matson, Assistant Professor of Nursing at San Diego State University, specializes in reproductive health and social determinants of health. Currently, Dr. Matson is collaborating with the Institute of Reproductive Grief Care on a reproductive grief screening tool, psychosocial care for pregnancy loss in emergency departments, and social determinants of health and psychological care in primary care. Then, last but not least, we have Dr. Kara Buskmiller, who is a board-certified maternal fetal medicine physician practicing fetal intervention in Austin, Texas. Her research and clinical interests include the ethics of maternal fetal and fetal-fetal vital conflicts and grief and reproductive loss. Dr. Buskmiller is the lead researcher on the Institute's reproductive grief screening tool and with collaborators at Baylor College of Medicine. She holds 2 patents. It is wonderful to have all of you with us today. So thank you so much for being with us.
Thank you for having us.
Before we jump into all of our participants, we want you to know that at the end of the webinar, we are going to have a Q&A time. So as we are talking with our researchers, we really encourage you to go ahead and put any questions that come up for you throughout the process into our Q&A box so that we can address those a little bit later. Well, let's get started. If we can, I'd like to hear from all 4 of you. So we just kind of do a quick round robin just on if you could share how you each became interested in reproductive grief care research. Let's start with Dr. Matson.
Hi, so my interest in reproductive grief care research really began at the bedside when I was caring for high-risk women, pregnant women who spent weeks or even months in antenatal units. I witnessed how the medical system could provide excellent clinical management, but still left patients feeling lost between that hospital and home. So with that, what really draws me are the opportunities to address these gaps in patient care experiences in the healthcare system, where communication falters, where patients aren't fully informed or emotionally prepared, and where the transition from acute care to everyday life feels so large. So I really want to understand that bridge and that space, and that really draws me to do research.
Thank you for that. No, we are so glad to have you as one standing in the gap there related to those things. Dr. Berry.
Yes, I first became interested in reproductive loss research when I was trying to help my sister navigate the healthcare system when her first pregnancy was complicated by anencephaly. And as I was helping her, I realized that parents are completely alone and isolated and without the support. And not only is the healthcare system ill-equipped, but society in general is not prepared to support families. And so that really sparked my interest in how can we as healthcare professionals bridge this gap in care and make the worst experience of their life be as least traumatic as possible.
I think your experience is one that many of us have, which is we get into this work from our personal experience. So thank you so much for both sharing that and for the work that you're doing in this area. Dr. Busmiller.
Thanks so much, Rebecca. Yeah, similar to the previous two colleagues, I work in fetal intervention and I only deal with high-risk fetuses. So these babies tragically are at a high risk of miscarriage and stillbirth. So because I offer so many things that are curative, I think it's easy for people in my profession to willingly or not drop patients or not have a lot of answers or not feel that we have much to offer families who then experience a tragic loss. And we can offer condolences, and that's important, but there's so much more that needs to be done for these families, especially if they've traveled to a fetal center. So gradually, as I was working in a sphere that offers so much for families who have continuing pregnancies, I realized we should have just as significant an armamentarium for families who don't have the same experience.
You're in such a critical position to be able to directly impact those families with the work that you do. Thank you for that. And Dr. Gonzalez Vieira.
Yeah, similarly, it came from working at the bedside with patients, right? I had so many patients that have perinatal loss at different stages that it was really hard to work through those cases because there's a lack of knowledge of how to work appropriately with these patients. And so, in that same process, as Dr. Bosmiller and I, we were doing training together, and eventually she invited me to join along. And I was really excited for that opportunity to be able to develop more research to help our patients.
I know it's exciting for us on this end to know that at Texas Children's, we have such an amazing team for you all being able to work on this together. So thank you all for sharing. Now, moving more a little kind of into the present, just thinking about what motivates you now to continue this type of research. If we can, again, go around and just hear from each of you, going back to Dr. Matson.
I think there's a few motivations. One would be seeing how patients' emotional needs go unmet. And even when they have medical care, they're not having that emotional need met. And I think from caring from those patients and also from, the different personal experiences, that really motivates me for us to be a platform and a voice for those who don't have it and a means for change.
I love how you bring up the emotional aspect because I know in healthcare, of course, those physical aspects have to be addressed. But when we're talking about reproductive loss, it goes so much beyond that, right? It's just that there's so much of that emotional aspect, and that you all are on the ground zero of helping to impact in a positive way how care providers can address that emotional emergency is really important. Let's move on to Dr. Berry.
And to really echo what Dr. Matson said, it's that need, that desperate need that is there. And honestly, I find it quite unacceptable that we have not met that need, especially with my nursing background and our emphasis on holistic care. we have really dropped the ball in providing the emotional support that families require in order to be able to heal in their grief. And so, in part, it's a huge part, it's the need. And the other part that motivates me is in my qualitative research and getting to talk to patients and hear their stories, hearing their resilience and their love and their growth is very inspiring and probably the number one thing that motivates me to continue this research.
I'm really glad to hear that idea of the post-traumatic growth, that it's not all just about focus on the grief, but also helping clients and patients to be able to realize that it is possible to get to a place where that from this experience, there can be some good, some growth that comes from that. So thank you for that. Dr. Busmiller.
I'm so motivated to see that as we continue to study this issue and use our research insights at the bedside to improve care, that nursing at the bedside and families at the bedside really do respond with gratitude, with excitement. I do some continuing education on this topic for our nursing staff, and every time the response is, "Thank you so much. This is so important." And that's not about a particular presentation or particular person. It's about the importance of the topic. And so I'm encouraged because as much as we continue to talk about it and research it, people are eager for more, and the positive changes are being made.
Mm. It's really noteworthy to me as I think of you all being here. We have those of you with background in nursing care, we have surgeon, we have psychiatrists. So we have really covering the gamut here of different types of providers. And that's so exciting because it means that we're addressing a standard of care across the care continuum and not just one area. Dr. Gonzalez Fieri, your thoughts?
Yeah, echoing everything that has been said so far, I always describe my job as very rewarding in itself, but I think there's like a special part of my heart towards perinatal loss. And I feel like it can be so impactful to be there for my patients who have had this experience that does not compare to other things that I work with in the clinic. So I think there's just so much to learn in this area that can be so impactful to so many people because this is so much more common that we tend to think about. And so that motivates me to keep pushing forward and making sure that research is done in the right areas.
Oh, well, thank you, all of you, for sharing that, for really giving us a glimpse into your motivations and letting us get to know you a little bit better. We're going to take on a couple kind of thematic topics moving forward, and one is really looking at what we're calling groundbreaking findings. And if I could direct my first question at first Dr. Berry and then Dr. Busmiller. And this is, what is one key finding from your research that you believe has most changed the way we think about reproductive grief care?
It is a great question, Michaeline. And I would have to say that it is looking at the emotional emergency of the reproductive grief experience. In my research, I'm looking at trauma and the traumatic impact on families, that emotional trauma. And unless we recognize that there is an emotional impact, that it is emotionally traumatic, then we cannot respond accordingly. Because the first pieces of trauma-informed care is first to recognize that it is a trauma, and second to respond with trauma-informed care. So if we look at reproductive loss as if it is simply a physical experience like appendicitis, we move forward and it's not meaningful to that individual. We don't realize and respond to the unique needs that they continue to have after the physical piece of their reproductive loss. That emotional piece continues.
Dr. Busmiller?
Yeah, I think from my research in formulating the reproductive grief screener, which is a 5-item questionnaire we're trying to design to screen for complicated grief after reproductive loss, what's consistently surprised me and the rest of the team investigating, including multiple people on this call, is that women are really grateful to be asked. And I say women because currently we're only studying women, not because other people would be feeling different. But over and over again, even if we're trying to tease out, how should we word this item? Are we worried about how often we should screen? How should we screen? The enduring message is, please ask us. Ask us how we're doing. We need to be asked. It's a bit of a tragedy that there's not a robust and routine way to do that now. But I'm very excited that it's coming. That's been, I think that's going to be a major shift in the way we care for reproductive loss, because currently we don't have a way to routinely look for how is the grief going? You know, the grief is normal. All of us grieve and will grieve for a long time after reproductive loss. But how do we know that things are going as they should be? And this is, I think, going to be a good shift for looking at that emotional emergency.
Right. Yeah. Thank you both for sharing that. And I think we're tying that back into emotional emergency. And I certainly know from I get to speak with a number of providers as well as leaders within systems. And I do believe you all have literally made an impact there because there's much more openness to considering this as an emotional emergency, which then brings up a lot more for them of realizing, oh, we need to do care differently. So thank you for that. If I could ask, I have another question, and I'd like to address this first to Dr. Matson and then to Dr. Gonzalez Vieira. How has current research impacted the community and practice?
I think what we're seeing now is that reproductive grief research is finally translating to practice. So it's moving from not being discussed at all to some theory to now healthcare systems. So what we see is research and studies are being published in Lancet series, and Quenby and colleagues recently in 2021 reframed miscarriage and reproductive loss as not just emotional and medical events, which is important, but also started to raise this as a public health issue, which garners more attention and is looking at the psychological, social, and economic implications. And this framing really gave healthcare systems both the language and legitimacy to address grief as part of this clinical care, as well as the wraparound care outside of it. And so what we're seeing is screening and identification. Dr. Bucks-Miller mentioned how we're working on a study to validate this complicated grief screening tool. We're also looking at interdisciplinary collaboration. So nurses, mental health care providers, social workers, chaplains, research I'm doing with Dr. Berry, where we were just accepted for publication. We're seeing how this interdisciplinary training is moving that needle in helping providers feel more comfortable talking to patients. And then also this education and communication training that the Reproductive Grief Institute is doing, looking at language, empathy, follow-up care, and emotional recovery. So overall, research is really helping bridge this space between evidence and lived experience, and how healthcare systems are seeing grief as both a measure and quality and the ethical responsibility.
That is so encouraging. Dr. Gonzalez Vieira.
Yeah, so research specifically in trauma-informed care and emphasizing on patient-centered approaches has directly impacted the way that I communicate with my patients. So I'm trying to be very mindful of the words that I'm using, the framing that I use, in a way that I encourage patients' safety, empowerment, and respect for their preferences and the experiences that they've had. In this way, I hope to enhance their trust, reduce potential triggers, and promote that therapeutic alliance with my patients. And so that has translated also in, as an assistant professor, I'm able to give classes to residents, to medical students, and fellows that are training now in this area. Where when I did training a couple of years ago, because I came out of training about 2 years ago, none of that was happening. So now we're having that opportunity of actually promoting this in medical training, and hopefully it will become a part of the curriculum for everybody because we're recognizing how important this topic is.
It's just so exciting to hear the changing landscape as being part of this and working for the Institute. Just in a few years, seeing what impact has happened and how the needle has really moved. As you were talking about with research moving into practice. And Dr. Gonzalez Vieira, I love how you're sharing the practical pieces of, even with the language that we use, the words, the approach that we're taking with our patients, and learning more about what those things are best. What are the best practices that are really going to help our patients along their healing journey? It's really, really exciting to see. Well, if we can, I'd like to talk a little bit about emerging trends. So if we can, I'd like to direct this to Dr. Matson, and then maybe after that to Dr. Berry as well. Could you just talk a little bit about what emerging trends you are currently seeing in reproductive grief research?
Yes, so I think something important that's happening is that through digital tools, more and more we're able to collect from the patients information about their pregnancy, miscarriages. And from that, what's happening is in these large data sets, there is almost a shocking amount of evidence showing how many people are having miscarriages and how often it's happening. So what that is doing is it's allowing to bring attention to this unmet need, and this is then allowing this research to get published in high impact journals and giving it the attention that it deserves. So there's a clear movement towards trying to measure this and standardize the work to assess miscarriage. We're looking specifically at reproductive grief. And then also we can see from here, are we able to look at this from social determinants of health perspective? We're looking at age and different markers as well. There's also, like I said, attention looking at digital-based intervention, like different health-based apps. And finally, like has been mentioned before, this trauma-informed care and shared decision making. So we're seeing those be a part of miscarriage and reproductive loss care and research as well.
As a follow-up, Dr. Matson, I know you just referenced that you're able to get more information about patients and the miscarriages with some tools. Could you just expound upon that a little bit for those who are not quite as familiar with some of what those tools are?
So just in terms of emerging trends, so there's a women's health study that is being put on by Harvard and Apple. And so they're grabbing all of the data from these people who are sharing their research and they can see it, as well as something called Power Mom that's happening through Scripps Health. And then in those data sets and digital tools. So these are being made and then used for research. We can see that there's a large number of miscarriages in those different self-reported apps.
Wow, that's incredible. It's exciting to hear the ways that technology can be utilized now to really do some of this emotional work to help see some of these things that patients are needing to be able to heal. Really exciting stuff. Well, Dr. Berry, how about you? Emerging trends that you're currently seeing?
Well, to allude to what Dr. Matson said earlier about perinatal or reproductive loss now being seen as a public health concern, I have seen a lot of trends looking at the long-term impact of reproductive loss on not only the physical but the emotional health of the individual. We're able to see now, as we look further out from the loss occurrence, that up to 60% of parents are experiencing symptoms of post-traumatic stress up to 5 years after their loss. We're able to see that families have multiple health disparities, endocrine disorders, immune disorders, cardiovascular disorders, on top of grief, depression, anxiety, post-traumatic stress disorder. We're able to see by looking at that long-term impact that there is greater healthcare utilization, greater utilization of prescription medications. And even in this year, there were some researchers in the UK that published a very important study showing that reproductive loss is a significant health disparity and independent risk factor for maternal morbidity and mortality, meaning that an individual who has a healthy pregnancy does not have the same negative health consequences as an individual who experiences a reproductive loss. So we're able to see that impact down the road, which is very meaningful because it draws even more attention to the desperate need to focus on what we can do here and now in the moment of reproductive loss, but also that we need to continue supporting parents once they go home and begin to attempt to heal.
Wow. hearing the long-term impact is pretty significant. You know, it really flies in the face of what a lot of people who experience reproductive loss may hear from others, which is you should be over it by now, right? Or some of those kinds of things. And it's wonderful to hear that we're starting to get some of that more longitudinal data that we can see the larger scope of what the impact of this issue is, and therefore then what we can do in real time now to help mitigate some of those longer term sequelae that can be problematic for people. Thank you so much. Along those same lines, so Dr. Buskmiller and Dr. Gonzalez Vieira, we'll start with Dr. Buskmiller. From your perspective, what are some areas of care that are just beginning to get the research attention that they deserve in this area?
Yeah, thanks for that, Rebecca. As much positive work has been done, I think there's more yet to do. So the first population that jumps to my mind is the partners, especially men. We know that men grieve differently. That especially young men who are typically the fathers involved in when women are at reproductive age, they don't usually participate in healthcare to the same degree that women do, right? Many times they're more often uninsured, sometimes by choice. And so they're harder to reach both with studies and with clinical medicine. Yet we know that they still do grieve, and their grief is actually more often prolonged and more often more difficult to work through because they themselves sometimes have beliefs about how they shouldn't feel XYZ, and then they kind of run in different circles that are sometimes expressing emotions differently than their female counterparts, and so they have a harder road to hoe in some ways. And I think studying that population is really important because reproductive loss is almost never just experienced by the one person. And then I think there are other populations that are not even at the fringes of these situations, but we've treated them as if they're at the fringes. I think one of the most powerful examples is the couples going through IVF, and our colleague Clay Brigance, who's been working with the Institute for many years, is paying attention to this population in particular. And I think that those couples go through something similar, really similar, and problematically similar to the patients who are experiencing reproductive loss after fertilization. And they've kind of historically been left out of studies of the psychological impact of pregnancy loss. But I'm really excited to see organizations like the Institute and independent investigators moving to study men, moving to study infertility patients, moving to study multiple other populations, grandparents, for example. And then also moving to study populations that may not experience the same kind of cultural impact of pregnancy loss as we might in kind of a Western English-speaking world. So I think the more that we sort of broaden and let the ripples continue of paying attention to these experiences, the much better. All humans know someone or themselves are touched by this.
I love how you mentioned partners, men particularly, because we just hear repeatedly as we work with different organizations, providers saying, gosh, I just wasn't even thinking about the men. I get so used to in our care provision focusing on her and her needs, obviously, because a lot of them are physical and have to be attended to immediately. And there's just not that thought about the male experience and the couple experience. As you said, Dr. Brigance has shared some about not only is this an individual journey, but for those who are in couples, it's a couple process as well, and that there are dynamics there that can be very different from just the individual journey. So thank you for bringing that up and that to our attention. Dr. Gonzalez Vieira, your thoughts?
Yeah, I'm just gonna add to what has been said already because everyone has said so many like valuable things about this. But in general, I definitely agree with Dr. Buskmiller in terms of like the populations that have been studied now, they have been expanded, especially the infertility um, population in particular. I think in the last couple of years, there's been some studies acknowledging that that is a type of grief, and we still have so much more to gain insight into that particular population, but also from different minorities in like in an ethnical way, thinking about that. I know like there's been like multiple podcasts and books that people are like trying to come out and trying to talk specifically about how the cultural differences are playing an impact in how grief is manifested across different cultures. So definitely think that's something that's emerging and a space for a lot of research to be done yet. And then another aspect that I think in part was brought because of COVID is the technological interventions, right? So now we have access to a lot of like telemedicine interventions or even like check-ins through apps in particular. So I think that has brought something new to the table in a way that maybe we can improve patients' accessibility to care, hopefully in the future. And that can definitely is a space where research is starting to be touched on, but definitely a lot more needs to be done.
Dr. Gonzalez, if you don't mind, if I can just touch back on one of the items you referenced about minorities. I know that's come up a couple different times. And I was just thinking, do you have any particular insights that as an emerging trend, that as a psychiatrist, that you are seeing that are coming up for you related to minorities' experience of reproductive grief or the process of healing from that is particularly culturally laden?
Yeah, yeah. Well, so for me, for always, it goes back to like patient examples, right? And so for some of my patients from the Native American population, they talk about how like the placenta has like a very like important role as well. So kind of like honoring even like what's done with the placenta can be important. So that's like the first thing that comes to mind. So I definitely think whenever we're talking with patients, we should be addressing like what cultural practice they have, what religious practice they have, and seeing what ways we can honor their religious and also their cultural beliefs.
Yeah, thank you, Dr. Gonzalez Fiera. And I think you help us to lead right into what would be kind of our third theme. And as a little reminder, I'm sure questions are popping up for those who are participating. Please put those in the Q&A box because we're going to be getting to them soon. And I'm going to do this more as a round robin. I know that Dr. Matson has been experiencing some technical difficulties, so hopefully she'll be able to pop back on again. But I'm curious to hear from each of you about future studies. So this is my first question that I'm going to pose. What gaps in research to strengthen compassionate evidence-based care are most urgent to address? And if we could start with you, Dr. Bussmiller.
Yes, thanks so much. I think the biggest gaps are the ones that are in education, in medical education, not only for physicians, of course, but also for nursing staff and for others who encounter these patients. For example, in the ER, checking people in imaging. Sometimes the most painful part of the story is how the ultrasound tech or another imaging technician was silent the whole exam. And that's not a comment on any particular career. It's just a comment on everybody who touches these patients needs to know how to speak to them, how to engage with them as humans. So I think it is yet to be clearly studied how we change these fields in education. I think we've got nurses on board who know how to educate nurses. We've got physicians on board who know how to educate physicians. And the Institute has significant experience in training the ER. So getting buy-in from leadership in the ER and training the people who will show up at a training. But it's difficult to reach sometimes the more contracted workers and the people who have less experience in sitting and accompanying a patient through something difficult. So I think that's one of the final frontiers and finding out how exactly to close those gaps in the experience of these families is going to be one of the kind of the most critical to make the experiences a little less like a flashpoint trauma moment.
Right. Oh, thanks for sharing that, Dr. Bussmiller. And I think right, we all can think of that. We hear it anecdotal, we see in research that what happens, that bad news delivery in particular is like seared into the memory. And that can either be a source of comfort or a source of great distress. And obviously that's never the intention from a care provider. And I'm thinking, because you're talking about education, that made me think immediately of you, Dr. Matson. And so the question being kind of what is an area of future study or a gap that is like, in your opinion, is the most urgent need?
Yes, I would say it's on a system level. So what Dr. Bussmiller highlighted was showing the individual level, which I think is so important. But I think in order for that to work, there has to be a system level understanding, acceptance that this is a need and that we need to be trained, but also we have to acknowledge that too and have something in place that is really ready to facilitate that communication. And I think that is really important.
Yeah. Thanks, Dr. Matson. And I'm thinking there that something that we have seen anecdotally, so I'm going to say this is not in a specific research study, but nurses in particular who've taken our education and have said, well, I thought I might be missing the mark. Now I know that I'm missing the mark, but I am not empowered to actually do what I've just learned. And so having that system buy-in, which makes me think of you, Dr. Barry. So what, in your opinion, is like the most urgent need?
Well, honestly, I think Dr. Bussmiller and Dr. Matson could not have prefaced my response any better. There is an urgent need for that education, and it needs to be adapted into pre-licensure education, not just after professionals are in their career and their practice. And it needs to be a system-wide adoption and culture change. And we need to look at the long-term impact. So we have cardiovascular care and endocrine care, and we have all these long-term models for caring for conditions that require continued follow-up, but we don't have that for reproductive grief, and we don't have that for reproductive loss. And I think that is the huge piece that is missing. While there are multiple huge pieces missing, it's a really important one. And I think the exciting thing is that with education, we can empower healthcare professionals to make a positive difference, and we can empower them to set the stage for healing as they interact with and care for these families who are experiencing loss. So, with these changes, we can do some dramatic things to the system with education, with system buy-in, and then with continuing to care for these families in the weeks and months after their loss.
Thanks, Dr. Barry. I'm curious for your thoughts, Dr. Gonzalez Vieira.
Well, ideally for me, right, I work in a reproductive psychiatry clinic, so I'm working outpatient, but I also see patients in the hospital per se. So I would love to see some effective, low cost, short and long-term interventions for patients that are scalable. So what does the patient need in the immediate moment post-loss where so much is happening? So we do want to deliver an intervention in that moment that will be effective and not re-traumatizing, but also we do know that they need that kind of like follow-up. And so thinking of it from like a systems perspective and everything, unfortunately, like money is important in all of these things. So we want to think like what would be a low cost intervention that's easy to be made by multiple disciplines within those who come in contact with patients so that we could all deliver the same type of care, the same type of interventions, and that would hopefully lead to like better outcomes.
Okay. Oh, that is beautiful. I love how each of your responses built upon the others. And it also leads right into my next question. And we're going to ask again, we're going to go around with this because what you've all talked about, right, urgent needs, I think we're all convinced. But it sounds like this is not something that just like one person or one organization can accomplish. And so I think if you could each touch upon like what kinds of partnerships do you see as critical for advancing the field? And if I could start with you again, Dr. Bussmiller.
Sure. Thanks, Michaeline. I think thinking of my field, we have professional organizations like the Society for Maternal Fetal Medicine, the American College of OBGYNs. I have the International Fetal Medicine and Surgery Society, which is altogether too much mouthful. But I think having the support and cooperation of these organizations is very critical as we try to disseminate and normalize a strategic approach to reproductive loss. One of the big benefits to patients who had heart attacks maybe 10 years ago was that The 10 medications they all needed got very standardized, were very rapidly adopted by the AHA, and then that was all propagated through other medical organizations. And so that just became ritual in the ER the minute someone was suspected to have a heart attack. This is a heart attack of a different kind. I like to point out that this is the biggest thing that will happen to the family that year, unless there's a lot of other things going on, which is unusual, but can happen. But if that's the biggest thing that will happen to that person all year, then we should have a standardized pathway, to Dr. Gonzalez Vieira's point, of what interventions they undergo in the emergency acute basis, and then what interventions they undergo in the following 6 to 12 months. And so I think having organizations that are used to propagating protocols at our backs is going to be critical in the next 5 to 10 years.
Oh, thank you. Dr. Matson?
You know, I almost don't want to follow that because it's so impactful, and a heart attack of a different kind that just like hit me on a very different level. But I would just say, in a smaller and organic way, the kinds of collaborations that we're seeing right now through the Institute with us, we're all from different universities across the entire nation and working on multidisciplinary teams, putting that into the hospital setting. I have never had the opportunity to be so privileged to be able to work with such a diverse group of people in the sense of setting, you know, across different borders. And I'm seeing that impact. And I see it translating in a lot of different research areas currently too. So it's very exciting to see some of these walls be taken down between disciplines, and instead we're building bridges. And I think that is going to really change research in healthcare.
Oh, that's great. Dr. Berry.
And in collaboration with what Dr. Gonzalez said, there is financial implications to all of this care. And so we really need to get stakeholders on board, because the hospital and the healthcare system is ultimately a business, but we need to be able to show these stakeholders that it is a smart business model to have effective care and put the resources in up front with educating the providers, educating the healthcare team, and providing the resources that families need, the counseling and therapy that they need in the immediate moments following the loss, as well as those in the weeks after their loss. And if we can look at how there will be a cost savings overall, which, looking at this in a financial lens, is disgusting, but it is still a business and we still have to be able to finance this in some way. And so we really need to get those business individuals who are the key stakeholders making the decisions to see the impact that this will have and how smart of an investment it is, not only for the money, but for the communities that we are serving.
And Dr. Gonzalez Vieira.
I sort of like agree with everything that has been said across the board. I think about it like short term, what partnerships are important so I can help my patients, and then about long term, where do I want things to go? So short term, definitely, like there are partnerships between us and the institutes that have been happening, and so sometimes I may invite someone else to maybe do a grounds round at the hospital, or maybe I'll give a talk at somewhere else. So I think those partnerships are very valuable. I met someone at the symposium who is actually the president of missing pieces support groups, and so I recently recorded a podcast with them. And so they are a support group located in Houston mainly, but now they're like national. So I think building on those partnerships, like relationships, is very important in the short term, because that way we can make sure that they keep contacting other people, right? So they're like interested in developing curriculums from different support groups, and I put them in contact with Dr. Bussmuller. I was like, sorry, like if you cannot, it's okay, but trying to make sure to ourselves be a bridge for other groups and other people as well. But then also thinking about the key stakeholders, right? So when I'm thinking of education, then we need to get the ACGME and the medical field like excited about this, make this part of what they consider important for like residents' milestones, because that's the best way for things to be included in our stuff. And then the major organizations as well, because if it's going to come with the board exam, then the residencies are going to try and like show this. And of course, I come from medicine, so I'm talking all in medical terms in terms of organizations and everything, but I think it's the same kind of model for any field and any discipline that we're on. So kind of like getting those the higher ups invested in this is key to make this something long-term, sustainable, and scalable.
All of you had so many helpful things there, because it is so true that while this is individual in how we respond to those clients or those patients in front of us, it is also organizational. And we do have to build those partnerships in order to make long-term policy changes and things like education, right, before they get their licensure and those kinds of things. I really love, Dr. Gonzalez-Vieira, that you mentioned the symposium, because I know for me, that is where each year I get to see such a clear example of these partnerships being built, where we have so many professionals that come together from all different areas of the country and all different service provision areas, but they're all coming together for the same purpose. And it's really, really exciting to see. Actually, some of the partnerships here between us have come through the symposium, and just being able to see those gain fruit has been a very exciting piece of working for the Institute. So thank you all for all what you are doing as a piece of that. And just overall, this has been such an enlightening discussion. So I really thank you all for sharing what you have and just your insights on all of this, and the ways that you're bringing research and some of these sort of more heady concepts and showing how they are playing out in real life, in practical work now with our patients. And that is very exciting to see. Well, we are about now to open it up to all of you who are participating. So we want to have a Q&A time so that you all can ask some questions of our researchers. So hopefully you've been doing that and putting in some questions. I see some in the Q&A box now. If you have not done so, please go ahead and do that right now, and we will try to get to as many of those as we can. So while those are coming in, if we can, I would like to start with one question, and maybe we will start this time with Dr. Gonzalez-Vieira. What research-based insight do you wish was more widely understood and applied in practice?
I think it would be that we need to screen for complications related to perinatal grief, so that we could actually come up with treatments to help patients that may have, something else after grieving, whether that is postpartum PTSD or an anxiety disorder. But definitely that we need to, because we know this is happening, then we need to screen it, and definitely we need to treat it as well.
We can't treat what we don't know, right?
Mhm.
Which is why it's so exciting that we do have that screener tool being worked on right now, which is really looking forward to that. If we can hear also from Dr. Berry, your thoughts on that, just a research-based insight you wish were more widely understood or applied in practice.
I really wish that it was more widely practiced to have the education piece, like Dr. Busmiller said earlier, and with what Dr. Gonzalez has said about the screening. Not only does that screening need to happen, but those individuals doing the screening need to know how to have that conversation and how to respond when an answer is, yes, I have experienced a loss. Because not saying anything, not responding to that can make a difficult experience much worse, and that can re-traumatize the patient. And so by providing that education and equipping our healthcare professionals to care for these individuals, we can have better outcomes overall, not only for the families who are experiencing the loss, but also for the healthcare professionals who are providing the care. Because as they're providing the care, they're not doing so as a heartless robot. I mean, anyone who goes into this field wants to make a difference, and they want to help people, and nothing feels worse than knowing that you don't know how to take care of them, or worrying that what you do is going to harm them more. That's not why we went into this profession. So providing that education, I think, is really, really important. And research absolutely shows that when individuals are equipped with the knowledge, that they are able to provide much, much higher quality care.
You really brought up a really great point about the importance of that training, and that really it's not so much that people don't want to do it. Vast majority of the time, it's just they have not been trained. They don't know what to do. So when we can provide that training, it brings confidence, it brings comfort, and it brings just the ability to meet people where they are. I'm kind of drawn back, Dr. Buswell, I'll go to you next. I'm kind of drawn to the comment that you made earlier about it's about how we engage with them as humans, right? That human care piece. Sometimes it seems so simple, and yet often we miss it. So your thoughts on this, just same question, how research-based insight that you wish were more widely understood or applied in practice?
Yeah, thank you so much. I think there's so many dimensions to this topic, and I think something that's really that has really been published on in significant volume recently is care of the caregiver and the second victim. So I think as we're thinking about educating people and improving their skills and improving their comfort with dealing with these situations, we also need to remember that, again, from a systems perspective, people who take care of these patients in the ER, sonographers who scan these people in the ER, they might need a check-in from their manager. How are you hanging in there? Like that was quite a lot. That pregnancy loss was really late. Have you had one of those before? And we may need to strategically shift, towards more senior personnel taking care of these. Whereas I think the current approach now is miscarriage, simple, not a diagnostic mystery. The grad nurse can do that. The new sonographer can do that. And so I think we know so much now about caring for the caregiver and second victims that I think we need to start to incorporate that into practice with unit dynamics and resource utilization during especially the acute presentation of these pregnancy losses. So I think that's something that will eventually naturally roll out as people pay more and more attention to this as the thing we're talking about, a serious life-altering event, both for the patient, but also for the medical team, just like a patient death in the ER is.
We got to care for the caregivers. This work is tough and it impacts those who are caring a lot. And that's a hugely important piece. Dr. Matson, your thoughts?
Yes, I think we need to ask the question. So if we're translating that to practice, I think we need to ask the patient, are you okay? And I think just the acknowledgement, we're seeing that in the research, this is being studied more and more. I think acknowledging it and being okay with acknowledging it in healthcare spaces is just really the critical first step.
Oh, thank you so much for that, Dr. Matson, right? And that certainly is. I mean, we certainly have seen through research this is a disenfranchised loss, and we know that that can have really negative outcomes. And so asking the question or acknowledging the loss, as we know, seems simple, but has a profound impact. Well, this is a question that we received from one of our participants. We'll do our best to answer it. I'm actually going to direct this at you, Dr. Bussmiller. Leah is saying thank you so much to all the panelists and to the Institute for hosting this webinar. I'm curious whether there's been any research on communication with patients experiencing IVS loss. And she gives an example, like when a clinician calls to share how many embryos were viable after an IVF cycle, or whether an embryo transfer was successful. She's commenting she thinks that's emotionally complex and just is wondering, is there any best practices or is there more research needed in this area?
Yeah, I'll jump right to the short end of that, and there is more research needed in this area, but there already are some articles coming out, which is really wonderful to see. I think in the past 5 or 10 years, there've been a couple of sort of more commentary-like articles, nothing rigorous that I know of, but a couple of editorials, a couple of kind of perspectives, mostly from people who've done IVF for a while. I don't practice IVF, so just a clear disclosure. I went through OB residency, and that includes some training in IVF, but I did not do that in my practice. So, but there have been people reflecting on, we do have some real impediments to communication. Some of those impediments include busy IVF clinic practices, right? There's just a storm of things going on in an IVF clinic at any given time. Failed stem cycle or a non-viable embryo or a whole bunch of PGTA that is just all aneuploid or all mosaic, that's devastating news. But it's sometimes you don't have time to treat it as anything other than just another lab result. So I think people within IVF practice, REI, and that population, that community is thinking about this, but we're still lacking kind of rigorous studies And there is some interest in education for communicating bad news. And really, there's lots about communicating bad news, but really importing that bad news communication into these conversations is sort of yet to be systematically and rigorously implemented, as far as I know.
No, it's really interesting because I think it's only been very recently that the realities of IVF and that there can be grief involved in that has even come to the forefront. And so it's heartening that that piece is included now and beginning to be addressed as part of the reproductive loss support needs. So I have a question for each of you just to give a brief answer on, and that is looking across your body of work that you have done, what would you say, what result or insight has surprised you the most? And maybe we'll start with Dr. Berry.
I would have to say it's the resilience of parents that has surprised me the most, honestly, because this is a deeply traumatic experience that impacts individuals physically, mentally, spiritually for decades after their loss. And they continue on living and not only continue living, but have post traumatic growth and live productive lives. And they live in the spirit of love of their child or children that have died. And so that to me is just so inspiring.
Oh, powerful. Dr. Gonzalez Vieira?
I think kind of in a similar manner, what has impacted me most is those patients that have decided to find some kind of purpose or logic to this. And so they've been able to make peace with their loss. And I think that's something extremely hard to be able to achieve. And it's not necessarily the goal, right? Like I always say, like, you don't have to be okay with this at all. But the fact that they're able to is always surprising to me, and again, really impactful to me as a provider.
Thank you. Dr. Mattson?
I think when we're doing, our studies, what we're finding is that people want to talk about it. And I think that is surprising in a sense because so often that voice is silenced. And so it just reiterates that need to do this research and to raise the voice up. And I think that, sometimes we just assume this is hard, people don't want to talk about it. And sometimes they may not, but in the end, that is such an important need that needs to be addressed. And so I think just seeing it over and over again in some of the comments, that can be, surprising.
Sharing stories can be such a powerful part of the healing journey. Dr. Buskmiller?
Well, Rebecca took mine because I was flabbergasted when research by Rebecca, myself, and colleagues at IUPUI, now IU, they asked participants who might who were of the same target population for the RGS, people who've had a pregnancy loss of a broad swath of kinds. How often do you want to be asked this? How often do you want to get screened with this tool? And they were like, all the time, right after the loss, and then again, and then every year. And I was like, oh my gosh, I had no idea that I was so under asking about how things were going. So I just, Dr. Mattson said it so politely, but I was like floored. I couldn't believe it. So I'll add a new one because a lot has surprised me with this research, and I thought I knew what I was doing, and it turns out not at all. And another thing that surprised me is just that the model of grief is a little bit different than adults losing adults, right? Adults losing adults, this is part of nature. We know it's coming. It's part of age. It's tragic when it happens how we feel too early or too fast or without reconciliation. But this is extremely well-trodden ground. And so all of us know this kind of as humans. And so, for example, the brief grief questionnaire, the 5-item survey that's meant for adults who lose adults or adults who lose children, asks them about accepting their loss. And the concept of acceptance is very well-trodden ground. Again, maybe you can debate that ground. I think that's very hotly debated sometimes. But the word acceptance was found to be particularly unacceptable to our population who underwent reproductive grief. And I think that's because in an even slightly good world, not a perfect world, maybe in a perfect world nobody dies, but in a good world, why should a child die? And so I think our population really found the word accepting their loss or acceptance, that concept to be quite unsuitable. And so we pivoted to different wording, something more like adjusting, because you do have to, in grief, kind of learn to live in the world where we are. And the world where we are is the one without your son or your daughter or the unknown, pregnancy that you had. And so I really thought it was interesting that my entire idea of how grief worked has really changed a lot and matured a lot since beginning this study. Something that is not meant to kind of be filed away forever, but something that lives with us in the here and now, always. Every time you look at one of the other children, for example, every time one of the other children moves through a milestone, someone else didn't. And so it's a very different model of grief. And so I look forward to how our understanding of grief, just as humans grieve, how that might become more mature as well in the 20 or 30 years yet to come after we pay more attention to this experience that so many people go through.
Oh my gosh, that's really beautiful, Dr. Bussmiller. And we're actually, and what a great way to conclude, because we are actually at the end of our time together. I'm so excited that we will get to see you all again here on the panel in person in March at our symposium. And I think for those who are participating right now, this gives you just like a little snippet of what's to come. And each of our panelists will be talking about their current research and some of their groundbreaking findings. So I want to thank you for joining us today. You are truly shaping and advancing a standard of care in reproductive grief.
Thank you so much for having us here and for all that the Institute does.
Oh my gosh. Well, it is our pleasure. It really is an honor to be able to work with all of you and to facilitate and be that bridge that was talked about. I do want to just really quickly thank all of you for participating today, as well as our sponsors, Indiana University, Indianapolis, San Diego Magazine, and Burnham Center for Community Engagement. And then we've mentioned the symposium, and I saw a discount code go up in the chat. So I want to be the first to personally invite you to join us on March 27th, 2026 for our annual symposium, The Next Frontier, where innovation meets compassion. Whether you come out to San Diego or join us virtually, you're going to have the opportunity to interact with all the members of our panel, as well as other grief care experts from across the country. So you can visit our website to learn more, take advantage of the early bird registration, and it looks, yeah, you have another discount that you can take on top of that as well. So I really hope that we see you there. And finally, as we wrap up Pregnancy and Infant Loss Awareness Month, let's all take a moment to reach out to someone who's been personally impacted with words of acknowledgement and support. And thank you, Rebecca, for co-hosting with me.
It was great to be here, and we hope to see all of you at the symposium.